When we first started talking about doing this program, we knew that we didn't know these speakers were going to grace us, but we knew that a session like this was going to be necessary. As you heard multiple speakers allude to, Dobbs really changed quite a lot, including what we consider sensitive data or sensitive information. And so to that end, we have 3 speakers up here who will be really important to hear from in this context. First, we have Dr. Jamila Perritt. She is the president and CEO of Physicians for Reproductive Health. She's a board certified OBGYN. She's worked more than 20 years in reproductive health and reproductive rights. She's also been appointed to DC's Maternal Mortality Review Committee and has a lot of expertise, particularly related to Black maternal health. Then we have Rachana Pradhan, who is a correspondent with Kaiser Health News. She has covered national health policy in a number of different aspects, and certainly after Dobbs reported on a lot of the same things that some of you got pulled into in terms of, period tracking apps and all sorts of things like that. So she'll be able to kind of give you a view of what she's thinking in terms of coverage moving forward. And last but not least, we have Jordan Wrigley. She's a researcher with the Future of Privacy Forum, and she's focused specifically on health data privacy. So with that, I'm going to hand it off to Jordan first, and let's give them a warm welcome.
Thanks so much, everyone. We're good. So I'm Jordan Wrigley. As you heard, I work with the Future of Privacy Forum, or FPF for short. We are a nonprofit think tank that combines a lot of thoughts from industry, from policymakers, from all stakeholders, and I work specifically in health data, health and wellness data, because there's a little bit of a divide sometimes when we think about these things. And of course, I was brought on in part due to Dobbs, because suddenly the landscape got a lot more complicated. What had previously been data that we maybe felt a little bit weird about sharing was suddenly dangerous and possibly weaponized against us being women, people who give birth, people who menstruate, people with bodies that may be vulnerable to abuse of that data. So just very quickly, I wanted to talk a little bit about how strange it was for me, and I'm sure many other people in the room, to suddenly have fewer rights than my mother did. That was one of the wildest things to me, to just really solidly put in a place where my mother had these rights and then I did not. And how that looks so different in a world where tech is now so advanced. And there are, of course, individual impacts. We are seeing already the challenges against abortion, life-saving care, dealing with what needs to be an abortion. Miscarriage is not something I do not believe, but happy to be corrected by my peers here. I do not believe miscarriage actually has an insurance code. I believe the actual insurance code is spontaneous abortion. And so that changes how we choose to structure our data. And this is something I learned actually from a journalist. There is no such thing as raw data. We make choices about how we structure data from beginning to end. And now how we structure data has to change in this new landscape to protect the people we want to protect, while also protecting the gains we've made. If anyone here can raise their hand, have you read the book Invisible Women by Caroline Criado Perez? Beautiful. It's amazing. It is my life's goal to end the gender gap and really bring us to terms with the fact that we have probably lost life. In fact, I know we have, because we have treated bodies with pregnancy, with menstruation capabilities, the same as we have treated those who can't, or with entirely different biological makeups. And we've continued to do so. It was only in the early 2000s that we really began to look at women in clinical trials and really involve them and even deal with dosing, which you'd think we would have dealt with, but perhaps not. And then as we went forward and we saw, and if you've read Invisible, and again, if you haven't, highly recommend it, we're seeing now what is attention between that individual privacy and continuing to try to close the gender gap in data. And I just did a quick lookup on clinicaltrials.org. As of 2021, there were 776 clinical trials active that related to pregnancy, abortion, menstruation, and this is a very loose search, so there's probably more. Just after Dobbs, 25 of them were withdrawn, terminated, or suspended. And that is ongoing. States that are abortion hostile are having to make choices. Doctors are having to make choices in light of trap laws, targeted restrictions on abortion providers. And that inherently impacts our ability to collect data that would further the foundation to make progress in closing that gender data gap and having better evidence for health outcomes for bodies who can give birth, be pregnant, menstruate, us. And so I'm always looking at ways to talk to industry, to talk to policymakers about how do we protect policy or privacy, while at the same time not losing the ground we've gained and not stopping the growth and closing that gender gap. So I'll stop there and turn it over to my peers, and I look forward to hearing your question.
Hello, good afternoon. My name is Dr. Jamila Perritt, as you heard. I use she, her pronouns. I am an OBGYN and I lead, as you heard, Physicians for Reproductive Health. We're based in New York, actually, although I live and provide clinical care in DC. And we're a network of almost 500 doctors around the country, really working to use the privilege that our white coat provides to advocate for the communities that we care for, particularly when it comes to reproductive health, rights, and justice. And you mentioned this 20 years that I've spent in this space, but you only said reproductive health and rights. And I really want to lift up justice here, because from the time that I knew that this was the work I came to do, it was justice-based work. It's always been liberatory work for me. And I believe that it is for most people that go into medicine. How we end up is a different story, but at least at the start, I think we are united in our hopes that we can build a system that is grounded in justice and equity for the communities that we serve. But I didn't come here to talk about that, so I'll look at my notes. A couple of things I think are worth mentioning. One, I've heard already in like this first maybe 10 minutes, but since the almost 6 months since the Dobbs ruling in June, over and over again I've heard Dobbs changed everything. Right? Dobbs feels, I think, to many people like this watershed moment or this culmination of a point of crisis, right? And so for those of us who have been organizing in reproductive health, rights, and justice for our lives, or even for 5 minutes, we knew that this was coming. Not to say that it wasn't devastating, right? It is, it was, and will continue to be. But we had been screaming and shouting since 1973 for folks to pay attention to what's been happening in our clinics, in our hospitals, in our communities regarding attempts to restrict the reproductive capacity of pregnant and birthing people, right? Understanding that this has been a moment of crisis for quite some time. Absolutely, Dobbs magnified it. And so for folks who were living sort of on the edge in communities, that at least it was legal to remove those federal protections. No question. But let's be clear, Roe never provided a guarantee of access for many, many people. I provide abortions here in DC. If you live east of the river and you're trying to get an abortion in this city, you might as well live in Nebraska. You might as well live in Texas if you don't have money, if you don't have resources, if you don't have connections, if you don't have job care, if you don't have child care, if you don't have job security, if you don't have all of the things that so many folks that are seeking abortion care need to actually make it a possibility, right? And so understanding that Dobbs is important, and Roe has never ever been enough. Casey has never ever been enough. So what does that mean about the increased risk of the communities that I care for and care about? I grew up here in DC. I'm committed to providing care in the community that made me who I am. And we continue to experience all kinds of manifestations of reproductive oppression. Dobbs is one manifestation of that. So what does it mean about the risk of privacy? This question about privacy, and I think the title is so interesting because the Roe ruling rests on privacy, right? And here we are talking, I haven't been here all day, so stop me if you've heard this before, but it's so redundant. It feels so redundant now, right, to think about this privacy rule and now us having a question about protection of privacy protections post-Roe. The thing that I think most about is not about privacy, but about what is the downstream impact of these breaches of privacy, particularly for communities that are made vulnerable by systems of oppression. Our privacy for those who are living at the intersection of multiple oppressions, whether it's gender oppression, racialized oppression, economic oppression, environmental oppression, have always been, we've always been at risk. And so our ability to be able to access care, our privacy has never been safe because our bodies have never been safe. What we are experiencing now post-Dobbs is not an increased risk of criminalization necessarily, but a broadening of the net because we've been at risk. And now all of you are too. That is the difference that Dobbs has brought to my work, and it should be the difference that it brings to your story. What happens now when white women lose access to abortion? What will we do? How will we fight differently? And who will we fight for? When we're thinking about how I hate the reinstate Roe or bring Roe back because we know that it was never enough. How do we think about what a new system looks like? Where are we talking about reproductive oppression and the intersection of those oppressions and how that impacts the way that people can receive care? And so that's the way that we think about our work in a much more complicated way. The challenge, though, because I do a lot of media, I do a lot of talking with reporters, and you all like good short sentences, and like little sound bites. And I am not parsimonious with my words, so I say all the words. And what I want to be really clear about in the next few words that I'm saying before I pass it along and make time for questions and answers is that you are obligated to tell a more complicated story. That is your job. Just as my job is to be in the trenches, to care for people, to go to the Senate, to go to the Hill, to talk with the president about the work that I do for the communities that I care for. Your job is to tell a more complicated story. We did not get here overnight. We got here because we all were complicit in this. Every single person. We bought into the system. We talked about it the same way. We wrote about it the same way. We told the same stories. We privileged the same people. And so now we have an opportunity because the floor is gone to build a brand new foundation. My ask for you is to understand that responsibility and to take it more seriously than you ever have in your life.
Oh, thank you for that. It's a tough act to follow. I'm Rachana Pradhan. I work for Kaiser Health News. We are a nonprofit healthcare news outlet housed within the broader Kaiser Family Foundation, just up the street here in DC, for all of you who are here in DC. So I've covered a lot of different healthcare issues, and of course, access to abortion and just the downstream impacts of the Dobbs ruling will be something that we continue to focus on. So I just wanted to, and you may have, you've talked a lot about data privacy, so some of these things might be repetitive, and so I'm sorry if they are. But when I think about how storylines might evolve or what really to think about, I've been in Washington for a long time, and so to me, there's almost always a regulatory reason, a legal reason, a policy reason as to why something is or is not happening. And I don't mean just abortion bans across the country, but when it comes to data, we don't really have strong consumer protection laws in America at all. And so that is really important when we're talking about privacy, when it comes to accessing this, what might be a life-saving medical procedure for someone. But the other thing too is when we talk about abortions now, I think it's important to remember just how abortion care is provided in the United States today and how it's different compared to 20 years ago. And why that's important for privacy. We have data now showing that over the majority of abortions in this country are done through medication, not by going to a physical abortion clinic where you need a surgery or other procedure. And I think, why does that matter when it comes to privacy? Well, I think that three ways I think about it is how is maybe the industry changing in response to the Dobbs ruling without government intervention? Google made this big announcement right after the Dobbs decision, and they said they're going to have blackouts of locations surrounding abortion clinics. Well, how many people still get abortions at physical abortion clinics? If you're picking up medication from a pharmacy, are you going to be protected? The answer is no. Even if you go up to an abortion clinic, all the data feeding into that is still visible. And if you track your periods on an app, if it shows you have a missed period, if you use social media to message people, if you've Googled anything related to these procedures, all of that could be used against you, which I think people have rightfully pointed out, which is why a lot of these things are really half measures. So one of the questions I would have is, what is the industry going to do without government intervention to try to shore up some of these protections for people? Similarly, I think when it comes to, I'm a health reporter, not a tech reporter, so when I think about in settings where abortion is provided in like a clinical setting, a hospital, an outpatient clinic, when it's needed, you know, we have all of our medical records now are electronic. We use electronic health records. Usually for care, broader care delivery purposes, the movement has been to kind of grant broader access to employees inside these facilities to be able to access people's information within, you know, appropriate bounds, right, or permissible uses. But even in states where abortion is still legal, you have clinicians who are morally opposed to that procedure. Well, do hospitals start to shift their behavior surrounding who gets access to some of this very sensitive personal health information, right? I think all of those things have a lot of, could have a lot of implications for patients that are really important. And so, including like misuse of EHRs, there are people who are coming from states now where abortion is nominally banned in almost all situations, and they're traveling to states where it is legal, but you still have a lot of vulnerability, right, in those situations. So the other thing I think about, again, with respect to regulation, about privacy. Currently, of course, we have a Democratic president. The Biden administration has interpreted rules surrounding emergency medical services, protection of personal health information, and other things to safeguard access to abortion to the extent that they can. That will change if there's a Republican president. And for example, rules around what is protected information under HIPAA, when is a clinician under even a court order, subpoena, or other legal law enforcement threat is required to share information about people accessing these things. The Biden administration has interpreted some of these rules to be very narrow, but almost with any change in government, some of these things will change. And I think that that's maybe, you know, not a tomorrow story, but it is something that inevitably, you know, interpretations of regulations change and they matter for a lot of people. And then I think the third thing that I always think about is people really don't understand, like, what is protected health information? Where does HIPAA apply, right? If you upload medical information from a HIPAA covered entity, a medical provider of yours, and you put it into any number of tracking apps that people use these days, it's not protected anymore just because it's your health information. Third-party apps, all these things, like, they are not HIPAA covered entities, and so they don't need to abide by all the regulations that apply to places like hospitals and clinics and pharmacies even. And people just don't know that. There are things all over social media that can be used against people. And I think that there's, like, with all these things, I think there's a patient consumer education story that's so necessary to be told, because and sort of in line with maybe government change, will there be a discussion about what is considered protected health information? That would need to be something that Congress would likely have to consider. And I'm not saying, you know, Congress these days, I mean, they really don't do much of anything. But I do think, depending on all the downstream impacts from the Dobbs decision, it's not unrealistic to think that one day that might be something that is talked about in either Congress or even other state legislatures that deal broadly with consumer data privacy issues. So I'll stop there.
Can I tell a quick story before we? I think because I think I love this, sort of all of the points of risk, right, when you're seeking abortion care, and just to make it really clear what that looks like in this country, right? If you find out that your period is late, and you're trying to figure out, your life is busy, who knows how late it is, but I think I might be pregnant. Maybe you have other kids, maybe you don't. So you Google pregnancy test, or my period is late, what do I do, right? That's your first risk right there, right in your Google search. And then you need to figure out whether or not you can get a pregnancy test. So maybe you're checking, maybe if you have insurance, you're checking to see if your insurance covers pregnancy tests, right? You're looking at, there's another risk. Maybe you don't know where you're going to get it from. You finally make it to the CVS, you get a pregnancy test, you check out, and you pay with your application, right? There you have another risk. Now you find out you're pregnant, and you're trying to figure out, well, where can I go to get an abortion? And so what do? You don't call your doctor, because most people don't seek out their primary OBGYN for abortion care. And instead, you Google it, right? And so you're looking up, where do I get an abortion? If it's legal in your state, if it's not legal in your state. If it's not legal in your state, now you're trying to figure out how you're going to get to neighboring states or several states apart, right? All of those are risks. And if you're in a place like Texas, then anybody who's driving you out of the state of Texas, there you go, also at risk, right? The people who gave you the money to buy the test, to get the ultrasound, do all of the things you need to do. So this goes on and on and on and on. Even if you make it to the abortion, to the clinic to get your abortion, and then you need to get your medications to follow up, you need to drive back home to wherever you are. If you have a complication, you go to the emergency room. And what happens when you go to the emergency room? Your risk goes up there too. Because we know, is anybody familiar with the study from Ipwin Howe, Lawyering for Reproductive Justice, looking at the risk of criminalization for folks experiencing poor pregnancy outcomes? So what they did was look between 2000 and 2000 and 2022, I think was the year span, the 20-year span. And they looked at folks who had been prosecuted for suspicion of self-managed abortion. Right? And I say very clearly suspicion, because there is no medical test to determine whether or not you've induced your own abortion because you self-sourced the pills or used the tincture or herbs or whatever it is may be, and whether or not I gave you the pill to do your medication abortion in particular, right? But they went to the emergency room. Somebody said, this looks suspicious. She looks suspicious. I don't think that this is a miscarriage. I'm going to call CPS, right? Because this is a minor. Or this is a mother bringing a minor in. And so now social work is involved, CPS is involved, the police are involved, right? Because those are one and the same, let's be clear. And so understanding that the risk of criminalization occurs so many times when we're talking about data, when we're talking about privacy, when we're talking about who's suspected of doing something, and when we're doing these things. What is the implication? Sometimes it is these period tracking acts. But what the study from Ipwin Howe shows is that the greatest risk is other people, interacting with other people. And so almost 50% of people who were, during a time period, who were prosecuted for suspicion of self-managed abortion were turned in because they saw it was in their case. It was a social worker. About 30% of folks were turned in because acquaintances or people in their community or family, right, were suspicious. They were pregnant and then they weren't. And there are actually only 3 states now where self-managed abortion is illegal. So, but we saw 26 states where the data was collected where people were prosecuted. So it goes to show you legality is not the issue. Power is the issue. Because prosecutors and legislators can throw everything like the kitchen sink. It's like the spaghetti on the wall, trying to see what's fit. So practicing medicine without a license, child abuse, endangerment, any disposal of human remains, anything, murder, feticide charges, right? All across the board. So the stakes are really high when we think about what the risk is now. So it is the data, and we absolutely should be concerned about how that data is used. And for me, though, we are a little bit downstream when we're talking about data and privacy, because the beginning of the story is how this person comes into the clutches of the criminal legal system and who is feeding them into them and how we can interrupt that as we're dealing with what's happening with the data. It has to be a both-and story.
Thank you. I want to open it up for questions.
I actually have maybe a basic question about education and legality. She talked a little bit about like educating people on how maybe to search for this information without leaving a trail or to find services. If you're telling them how to do something in a state where that is illegal, or where are we at that point?
We follow all the laws applicable in the states where we practice medicine, including doing consultation. So if it's not legal, then we don't do things. You got a classic response, right? That's what I'm told with them.
But as working for a publication with the legal department that likes to tell me not to do things, is that a liability thing? Like, would you be liable for that education process?
So I think it depends, right? The thing that's really hard to understand with what's happening post-Dobbs is that you have 50 different iterations of foolishness, right? There is no way to tell. What's happening in D.C. is different than what's happening in Virginia, is different than what's happening in Maryland, even though you can get to both, probably not right now, but most of you can get right? And so it's going to look different. There is no answer about what is legal and what's not. So we partner with there is an answer about what's legal and what's not, but what your risk is often tied beyond legality, right? It's tied to typically identities and whether or not folks are attempting to make a point. But what I will say is that we recognize that what's happening is that healthcare providers are being gagged and told that we can only tell one side of the story. I don't want you, though, to think that this is because of Dobbs. This has been happening for decades around abortion. Forced speech, gagging, lack of counseling, inability to do referrals. This has been happening in states across the country, right? And so if you are in Tennessee, for example, there are laws saying that I have to disseminate information that is medically inaccurate about fetal development prior to you having an abortion. Right? Or if you live in other states, you're unable, and you work in a Title X clinic, then you can't refer people for abortion care. You can't provide abortion care. So this isn't a new phenomenon, and the question is, how will it change now that we have lost federal protection? And I think it remains to be seen. We don't know. So we tell our healthcare providers we follow the law in the state where you practice, period. And we have organizations like the American College of OBGYNs and the Medical Association and the American Family Physicians, all organizing and working to say that doctors and medical providers should be able to provide unbiased, comprehensive counseling for every single person in front of them. And this does not allow us to do that, and we tie criminal and civil penalties to the care that we're providing. I know it's not a good answer, right? Because you should be like, yeah, she could do it, and you won't go to jail, or no, you should do that. They don't get you. But it's not black and white. Yeah.
I mean, what about the data brokers in this space, and not just the big tech companies, but the ones, smaller ones, medium-sized ones, that their whole business and what they do is about collecting and selling data in this regard. Like, I think about like how, right now there's like been examples of biometric data used in like prosecution cases, obviously, Fitbit data and stuff, and it's going to be it just seems like a really dangerous field at this point.
I'm a doctor. I'm not going to answer.
I can speak a little bit to this. Being from the state of Idaho and the reservation system therein, there's this great company called Coachella, you may have heard of. So data brokers, yes, data brokers are sort of existing in this sort of space where we're really not sure what's going on consistently, and surely policy has not yet evolved to give guardrails to that work. In an ideal space, data brokers that are part of industry would operate similarly to how researchers operate when they de-identify or anonymize EHRs for research. It's a great thing. We don't have any current guarantees that they are operating that way, though there are some industry standards that they may use to mostly operate that way. But in general, it's not good business for them to push it too hard, too far. And that's kind of, I think, what we're going to see in 2023 is like, you all had a chance to speak to Kirk, This is a little on the nose for me, but he says we got to wait to see for who finds the pitfall first, like who finds it first. And it does seem to be setting up on the FCC side that data brokers are a big liability in the data flow systems around health. So in general, to answer your question, I would say yes, we have a problem because these are sort of new entities on the playing field, and we don't yet have legislation and regulation to completely guardrail what they can do and the possible risks that could come to consumers and companies. There is a really good report in 2014 by the FTC that was very specifically calling for transparency from data brokers that's worth a look. But as of this time, I think the rulemaking that the FTC currently has underway is going to define a lot of what data brokers can do in the future.
Which is the only thing I would add to that is, right, like when you know the FTC is interested in some of these things, you don't really want to poke the bear, right? Like that's, I mean, if you do, it may not go over so well. But on the other side of that, the FTC's rulemaking process is extremely slow. We have 2 years of the Biden administration left, and we don't really know who's coming in after that. So, you know, all these things can be certainly are done. No regulation is permanent, right? So it could very well change.
That's a good question, because you're right. The FTC does have the advanced notice of proposed rulemaking on data usage. And I think the comment for that was like Monday, that the comment period ended, or last Monday. So what's the next, is it then like an NPRM, or do they go, like, what's the next step, and then timeframes?
If only there were a formula. So I would, I mean, so advanced notice of proposed rulemaking is like way early, extremely, right? You can have any number of, there's no real science to it, except to say time periods are indefinite. There are controversial regulations that sit with the federal government for years and years and years before they either get quietly shelved or before they're published. I don't think this would be any exception, just giving the topic, right? So you could have a proposed rule. You could have, if they really wanted to, you know, get spicy, maybe put out like an interim final rule. This basically means this thing is taking effect, and you have 60 days to maybe lodge some comments, protests, whatever, but it's going into effect on date certain. But that could be at any time in the future, right? There's no like mandate that says this needs to be out by a certain time. So, and then, not to be like the Debbie Downer on regulation, but you know, even if it does get finalized, I imagine that you'll see litigation to try to stop it, or Congress also has the power to nullify federal rules issued within a certain amount of time. So if they, which they've done, you know, and attempted to do repeatedly in the past on other topics. So, you know, it'll take a long time. I think I read, it might have been maybe in Bloomberg the other day when I was doing some reading on this, that, you know, the FTC's average rulemaking time is something like 5 years. I mean, it really takes a long time.
6.
Oh, there you go.
I'll be the Debbie Downer.
Oh.
The average under this
She said at least
particular process they started, which is the MAG-MOS process, right?
Yeah.
6 years, possibly 7. And so this initial comment period will define probably whether or not they're going to do it. If they get so many comments that have so many good points to say, do not proceed, they may choose to shelve it and be like, okay, never mind, forget that, you know. And that may be to some extent to allow other regulatory and legislative entities to come in stronger ways. Right now, the FTC has positioned itself as sort of, I don't want to say like the hero Gotham needs, but has presented itself as having oversight in these areas, and it is going to use that power. And this is a brand new way in which it's testing out that power. Again, the Kochava case, this is one of the first times we've ever seen unfairness without deception. You usually get them two at the same time. And in fact, I've gone all the way back to the beginning. FTC, I cannot find any instance where unfairness exists on its own. So that will be very interesting for the future.
So I've covered the abortion issue in Florida a few times, and what I've been meaning to ask an advocate was after Roe. Well, in Florida, we have the 15-week ban. I know Georgia, I think, is stricter. I think they have a 6-week ban. Yeah. So have we seen an increase of pregnant women actually traveling to the States? Because I've talked to abortion funds and they say they help out, with like the travel and other fees associated.
An increase, what, since Dobbs?
Yes.
Probably. I mean, I think folks are still counting to figure it out, and there's a danger in counting and figuring it out also. So like the trepidation around that. The demand, what I will say is the demand at abortion funds. So I don't know if you all are familiar with abortion funds. It's an organization called the National Network of Abortion Funds, and they're there primarily to fill in the gap for folks that need to access care. So they can help them fund the abortion, but also, as you mentioned, travel, and other logistics, childcare, all kinds of stuff, right? And these are independent funds that are around the state. And with this national sort of umbrella organization, they have seen such a huge demand since Dobbs, which leads me to believe absolutely folks are trying to figure out ways to access this care outside of their own communities when it's impossible. And that, it's not new, that's been happening. That's why abortion funds have existed for so long. But I think that folks will have abortion. That is the bottom line. And people have to do whatever they need to do to make sure that they can obtain the care that is best for them. And so we will continue to see an increase in folks traveling and seeking care. We will see an increase in folks self-managing their own abortion. We will see an increase in folks that are arrested and criminalized for the care that they need.
I think one thing, what I would just add to that is I think in the near term, we're still kind of in the near term, right? It hasn't even been 6 months yet. You'll see a drop, in states that pass these bans, like you will see a precipitous drop, obviously, in the number of abortions being provided there. But what I would say is from a kind of reporting data perspective going forward, not every state does this, but, frequently state health departments will publish as part of their vital statistics reports. They will publish reports annually on how many abortions were performed in their states, and oftentimes even break down where those people lived. Like if the numbers are large enough, they usually will provide state-by-state breakdowns. And so you could see, whether those numbers are increasing from out-of-state residents coming every year.
And that's a tough count, right? Because even in DC, there's no legislation mandating reporting. And so Planned Parenthood, which is the most commonly known provider in DC, reports. Independent abortion clinics, not so much, right? Hospitals, because I did want to circle back to what you were saying. There's a miscarriage is not a medical term. It is a spontaneous abortion or an induced abortion. So if we can just stop writing that, that'd be awesome. And use the medical language that we should be using. You can put miscarriage in parentheses if you want, but it's a spontaneous abortion, and that is the CPT code. So absolutely right with that. But there's not consistent mandate around states or even in cities to report induced abortion numbers in the same way. And I don't know that I would advocate for them to be, right? I don't know that there is necessarily a value in there that outweighs the risk of counting this number for folks, especially in this moment. And if you're tracking, the biggest challenge that we're seeing with folks that are traveling for abortion care is, I think you mentioned it, in folks who are traveling from places where abortion is illegal. So we had travel before, but it was typically because of things like gestational age bans, trap laws, right? So you were in Florida has a 15-week ban, and you were going to travel to North Carolina or to, I don't know what the closest one would be, maybe Atlanta, Feminist Women's Center in Atlanta, right, before Georgia had their ban, right? So you were traveling to seek abortion care, not because of a legal issue, but because you were a legislative one, right? These limits that were put in place. For the colleagues in our network, and I'm thinking of one in particular, when SB 8 went into effect in Texas, they had seen it coming because they had been yelling to all of us, pay attention to what's happening in Texas. And everybody was like, that's Texas. We're not worried about that. And lo and behold, here we go. But they obtained license in neighboring states because they knew abortion was going to fall in Texas. And what they told me was that prior to the passage of SB 8, maybe about 5-10% of their patients in this neighboring state were from the state of Texas. After SB 8, 70%. of the people on her roster for care were from Texas. The question that we should be asking ourselves, or you should be asking yourself, because I know, is what happens to the people, the folks that would have been on that roster who now live in the state where abortion was available and accessible and now can't get it because all of the influx of people from Texas. So there's this ripple effect. And so it is not unreasonable to believe that everybody is going to end up traveling, believe it or not, because even if it's legal, it may no longer be accessible in your state because of the volume of folks that are needing to access it, and now it's really fixed capacity.
Yeah, actually, over the summer, before the Dobbs ruling came out, I wrote this story with a colleague about abortion access in Minnesota, per your point. In Minnesota, which Democratic governor, state legislature is more conservative, I would say, on abortion, at least for like a blue state, what we would call a blue state in Washington, right? They have 8 abortion clinics where you can get an elective abortion across the entire state. Most of them are in Minneapolis, St. Paul, and in cities. So actually, when I was speaking to the Midwestern Access Coalition, which is an abortion fund in the Midwest, they were telling me that in Minnesota specifically, most of the people who they would fund were people going from rural areas coming into the city, because rural areas just don't have abortion clinics. And I think that's true in almost every state. You know, they're really kind of located in urban areas. And so, you know, it's true, like legal doesn't mean accessible. I was shocked that there were only 8 clinics in a state like Minnesota. That doesn't count the hospitals where, like, if you have a lethal fetal abnormality and you need inpatient, you have to be admitted and have these things, but where you can call the phone, pick up the phone and call and get an appointment. That's not very many, right? Like, so it's just interesting, but I think abortion funds are actually a great resource to you all in your reporting, because I also think obviously privacy is of utmost concern for them. They're using, encrypted apps and messaging because they know that they still have their work if has flown through the roof over the last 6 months. And so I think, they're also like great resources for kind of getting at least anecdotes for now on like how things are changing.
They are great resources, and if I could offer some recommendations and engagement with them, understand, as we said, their demand has skyrocketed. Don't call the helpline when you're trying to get information for your story. That's the line that people are calling because they need care. They're not going to connect you with a patient that you can follow and see what it means to try to access abortion, or to ride with somebody who's leaving Texas and going to Oklahoma, well, not Oklahoma anymore, right, and traveling. So just be mindful of what we're talking about, especially in this conversation around privacy, and whether and how any of the behaviors that you're engaging in are increasing the risk for either the clinic, the provider, the person seeking care, the people funding the care. Because with each conversation we have, with each piece that is written, that risk goes up for us. And so our plea is that you all remain mindful of that and understand that we want to tell our stories. And there are folks who are accessing abortion who are trained storytellers. We Testify is a wonderful organization, abortion storytelling, where they support, protect abortion storytellers. That should be your first stop if you want to talk to somebody who's had an abortion or needs an abortion or is managing an abortion. The abortion funds can give you lots of information, but understand what their work is and what the stresses are that they're under before engagement.
I actually remember even before Dobbs, there was a clinic that I emailed in Minnesota that was a mobile clinic. They mostly do medication abortion, and per your point, I know we're reporters, but and we don't always have the luxury of time, but they said, don't ask for an interview and say you have a deadline of a day. It's not going to work. Like, you have to kind of be patient, which I know we don't always have the luxury of doing, but this stuff is important. So I think giving them some breathing room, and it'll work out if we do, but just they have enormous demands on their time already, and clinicians who do the work too. So,
which is one of the reasons why our organization is really committed to training doctors to do this work, right? So you're not trying to catch up with somebody who is in the middle of care necessarily, or who has this full load, but somebody who actually understands what the story is we're trying to tell and can help support you in your work in the way that's best. So you are more than welcome to reach out to our organization if you want, and you should want, both a physician's voice and a patient's voice in the story that you're writing about care, whether it's abortion care or any kind of care, right? And so I'm happy to support any of that if you want me moving forward. Don't make it up. Ask, we'll help you.
This is only one kind of slice of the puzzle, but I was wondering if there have been any litigation or any cases that of any of this data being weaponized over the past 6 months against people who may have had an abortion or may have not, but the data kind of pointed in that direction. I was thinking of, when SB 8 was implemented in Texas, there was a lot of talk of anyone being connected at all. And it was like, oh, if your Uber driver drives you there, then they can, are connected to that. And I guess part of the reason I was thinking was that, we still have a right to interstate commerce. And so if you are living in Texas, but maybe go to Illinois or some other state, it's a different set of laws. It's a different, I'm not sure where this question is going. I guess I have a lot to say, but I guess litigation was, if that has played out at all related to the data over the past 6 months.
It totally has.
Yeah.
So
And not just in the past 6 months, but yes, start with that.
Wasn't with the Nebraska case, and then in Ohio also, right? Or the Ohio girl who went to Indiana when it was still legal. Wasn't there a data question about that? Or
It's a little bit different.
it's a little bit different. So the one in
The
Nebraska.
answer is yes, is the short answer. So,
The one in Nebraska is interesting, and I'm just going to talk about data structures here for a second. So what happened with Nebraska was a disclosure. It was information more so than data.
so that's a healthcare provider, right? That goes back to what I'm saying about people seeking care and where the points of risk are.
Right, exactly. So there was a disclosure, and that disclosure happened in Facebook,
right.
Messenger. But what was said is, I'm pregnant, and then the conversation about accessing abortion happened. And then the law enforcement came in under looking for, I believe it was a improper disposal of the body or remains. And then they found the messages. They went to Facebook and said, we want this. And when we face this subpoena warrant, it's very hard for tech companies to say absolutely no, and they're building those capacities to say no. Now, I think what we all are concerned with in the long run is actually the data being used and weaponized en masse. So when I think about things, here's fun fact, this is still very nascent research, gait analysis. Your gait can be more identifying than your fingerprint, especially when taken over time. A woman or a uterus having person's gait, if they menstruate, can change during menstruation or pregnancy. Now, this is very semi-accurate. It's very new research. But think about there's a reason why all you see on my wrist is pretty. Like, I'm just not comfortable with that. That's not a risk I'm willing to take. And so what does that mean if, in a sort of wholesale way, law enforcement could say, hey, Fitbit, Google, let's see all of this. And so there's not really flows yet to sort of harbinger that awful option, but it is a fear, it is a risk that we all need to consider when we're making our choices. And unfortunately, I like to make the case too that this is one place where it should not always be on the consumer. We saw that great presentation from Medtronic about putting all of the debt on the consumer and the patient to make all of their choices, where really it should be an obvious choice that maybe don't just wholesale give my data to law enforcement in this way. But to your point, and I, if there's other ones, I should hear about them for sure. But the one in Nebraska is the only one that springs to my mind as, yes, this was data.
Yeah.
Were there others?
And no, there were others, but not in the last 6 months that I'm aware of, but certainly prior to that, right? The woman in Pennsylvania is an example who had ordered medication online for her daughter with her daughter's consent. She's a minor. She was charged, arrested, imprisoned. Right? Same thing happened, but so, and they tracked, I think, messaging or Google searches or something with that one too. both of those cases, and most of the cases that we see, again, are because people sought care. So they started the investigation of the fetal remains and proper disposal of fetal remains because they went to the hospital and the provider there was suspicious that this, right? So thinking about, so there are lots of points where we think about it. It is the data. The data is the end. We have to figure out how they're collecting it and what they're doing, but then stop this initial inciting event. As well. I would offer for you as well some resources around like what providers are doing and to work on this upstream issue. So there's a group in New York called Interrupting Criminalization run by Andrea Ritchie, and we've really brought together healthcare providers to talk about all of the ways that medical sites act as points of criminalization for many communities and have come up with a wonderful set of principles called the Beyond Do No Harm principles that looks at that. It's not abortion centric, right? Because abortion is a point in time. It's what we're talking about now, but understanding that this is a life course conversation in terms of the risk of criminalization. So I would encourage you to think about sort of the way that those things marry, but there's lots of work that's happening to stop the prompt in the first place that results in the data mining, because we know that we haven't figured out yet who has the data, what they're doing with it, how they're going to use it against us, how it's going to be weaponized. The last thing that I'll say around that data and the subpoenas for lots of folks, right, including healthcare providers, is that we're doing lots of work talking with providers about medical record documentation. Because in the same way that we see tech companies turning over their data wholesale to the state in the carceral system, we are seeing hospitals and doctors and practices, when they get a subpoena, they indiscriminately, they're just copying the chart and sending it over, right? And so really being very clear about what we're writing in the chart, while we're writing in the chart, how we can document in a way that is protective for patients, how we understand what the harm may be by the words that we're writing in our chart, right? So all of those things, so upstream and downstream, thinking about how is this data going to be used and how could it be weaponized against this person that I'm caring for.
I know there's anecdotal data about Fitbit and Apple Watch detecting pregnancy with heart rate, and I don't know if there's correlations there, but is there any actual documented research about that?
I don't know.
I don't know.
Yes. Again, anything that detects pregnancy and menstruation is going to be nascent research. There's accuracy and precision issues. Does everybody know the difference between accuracy and precision? Accuracy, you're going for a known target. So if you imagine a bullseye with a bunch of dots, like all mostly spread around like the center point that you're trying to hit, versus precision, where they're all clustered in one spot, but maybe they're off center. And when you have accuracy and precision, they're all clustered tight around that center point that you want to hit. So when we use a lot of this technology, this data, we're looking at the difference between accuracy and precision. Now, Kirk, whom I love, Kirk and I get into it a lot. He tells me there are certain things that there's no way I can make a health perception about somebody. He asked me, well, what if I go to the DMV and someone owns cars, 100 cars? He's like, they could be just living in a junkyard. I'm like, are they insured? That would be part of the DMV. If they're all insured, yes, that person has access to health care. If they're not insured, they might be part of a junkyard, or they could be classic cards in some weird way. So there is a tremendous amount of research that points to the ability to look at the body as a whole, which in many ways is excellent. But there's a great podcast out there that is Caroline Criado Perez, who I mentioned, wrote Invisible Women, and Daniel Citron, who wrote another really The Fight for Privacy. And they talk about this exact issue, which is how does research help us, but then ask us to sacrifice our privacy. And so we want to find those things that help us understand our bodies better, but we do not want to have to sacrifice our privacy in the process. That has, to some extent, for some of us, not all, protected some of our rights to healthcare in this arena.
And one of the things I think about with respect to this issue, right, is like, consider, like you mentioned, clinical trials. If you think about a clinical trial for a new drug or a vaccine or something, we have regulations and guidance surrounding the process of informed consent. Well, informed consent means that someone needs to properly understand what they are signing up for, what the benefits are, what the risks are, and what is entailed, right? And we don't have informed consent when it comes to our data being used. And I think that that's really like, what are we really talking about, right? If you knew that like your watch could be used in that way, I mean, that's terrifying, right? It's just a watch, like, but how could that be used against you? And I just think people just don't understand. And it, like you said, it shouldn't be up to the consumer all the time to delete their search history, to turn off all these things. Like some of it needs to be, consent needs to be much more fleshed out and much more protective.
I have a colleague who insists that we need to do every form of consent the same way they do in the BDSM world. And I'm kind of into it these days. His name's Shay Swager at FTF, if you get a chance. And he's done some great presentations on this about how consent should be ongoing, consistent, constantly checking in. And it sounds very onerous for maybe many consumers, but maybe there's a way to make that functional in the text landscape.
I just have a question. In the past couple of months since the Dobbs ruling, I've been reading a lot about the communities on Reddit or through Signal or Telegram providing support systems for anyone seeking medical abortion pills that are, presumably going through the U.S. Postal Service at some point to get from point A to point B.
Yeah.
And I'd just be really interested in what you all think might be what might come of all of this. Of course, there's, a lot can change in 2 years and administrations change, but just what you all make of what is currently happening to support those who are seeking abortions, and specifically in this case of like mailing medication through the Postal Service, and what might happen in the next couple of months or years.
I mean, that's definitely a question that has come up amongst my editors and I, because given that, like I said, okay, so we have CDC data showing the vast majority of abortions occur in the first trimester, and medication abortion is authorized, I think, until 11 weeks, right? You'll know this better than me. But and most abortions in this country now are done through medication. So how are people getting it, right? I think there are some questions like, I think, could that be weaponized against you? I think it'd be hard to be clear, but it's definitely like a concern/question. It's not like the Postal Service just gives you your mail without going through. We all know they check mail all the time. And I think that's why sometimes you'll hear these anecdotes of people who maybe a minor, live in a state where abortion is not legal, right? They'll have the pills mailed to someone who they know, who can get it to them, or mail to, some other sort of indirect way so that they can access it, right? But I just think, I don't have a great answer to this, but I do think it's worth keeping in the back of our minds, just given, and there are also networks of organizations that sort of operate in this, delivering medication in a way that is sort of like operating within this legal gray area, right, of what they can do for now. So
I think that the question before answering it, right, is whether or not they are obtaining medication after they've interfaced with the formal medical system or not, right? When we're thinking about pills being mailed and what our risk stratification is around that. So this is the difference between self-sourced medication abortion and telemedicine, for example, or mail order medication abortion. So when you're talking about those folks that are operating in the gray area, those tend to be the people who are supporting those with self-sourcing their medication, right? If we have telemedicine, if we have a provider-assisted medication abortion, then it is legal to mail them back and forth, and so that risk, it does not necessarily hold the same risk, at least for the provider. Right, the patient, it's a different story.
I think there's some discussion also too, though, right, of providing access to medication before a woman may become pregnant, and that's the other thing.
Yeah,
too, right?
so there are conversations about this advanced prescribing, and these are the same conversations if any of you were writing about when emergency contraception went over the counter. right? And so many conversations about how we were going to move this forward, who was going to get access to it if it was over the counter, but still behind the glass, and sort of all of those things, and whether or not we were able to do advanced prescribing in the interim. First of Plan B, which then eventually went over the counter, but now of ulipristal acetate, sometimes known as ELA, and often many people do advanced prescription. But the studies haven't panned out in terms of whether or not advanced prescription equals increased use of emergency contraception. And so we're studying that now through research, lots of different research projects looking at this advanced prescription, and is it an opportunity to be able to improve access to abortion prospectively. The other way that it is shown up is advanced prescription, and I know we've digressed, I'm going to come back, but the advanced prescription is also shown up in research around something called missed period pills, right? So thinking about what that looks like, and this idea that you're living in the gray area, could you take a medicine even before you took a pregnancy test and bring your period back? This is a distant or a stretch, I think, in this country, but a common practice around the world. Menstrual regulation, bringing down your period, bringing back your period, and the suggestion of using this through, it would be the medication abortion essentially, but whether you knew you were pregnant or not, you just know that you haven't had a period, you need to bring your period back, you take this medication, what happens? The last thing that I want to say about this risk in mail order and what we're thinking about, again, goes back to what you all's role is and how you're writing about it. We had a really dangerous piece that was written not too long ago about missed period pills that actually disclosed the way that people were obtaining or self-sourcing medication abortion. So I'm not talking about the organizations that we know about Aid Access, who has been intentionally public, right, around their work, or other organizations like that, Women on Waves, right, and there are all of those kinds of things. But we're talking about people who are using alternative means, right, sometimes extra legal ways of obtaining these medications. And they actually disclosed where folks were getting the medication, putting the whole supply chain at risk, putting the people who were supporting at risk, and certainly the people who were seeking this care. So just being very deliberate until we can figure out where we are, what we're writing about in a public way. And again, just asking, if we are writing about this, is there some risk we are putting you at that I'm not aware of? Because my expectation is not that you know, right, all of the things that could be theoretically risky. But going back to this conversation about consent, frequent consent when you're doing a process. Hey, we're thinking about writing about this. What are the things I might be missing? Is there a risk here for you or your community that I'm not aware of? And is there a way we can tell this story and minimize that risk?
I'd like to build on that just a little bit because you mentioned in passing Reddit. Social media and online networks are currently one of the best ways people have to access some of these networks of help. So when you're writing, also be careful, like if you disclose the subreddit, that which people are getting help with, Reddit will have to come in and shut that down. They will be required to. So being very sensitive, or like law enforcement entities maybe, oh, subreddit, we're going to go download all this data or warrant or subpoena it. And if I can have one last request of you all, one of the things that has come to my mind and I think is sort of on my docket for 2023 is there are several states, well, a handful, that are starting to look at privacy protections. Colorado, Washington, Connecticut, Utah, Virginia are the ones that come to mind. And in particular, there's some specific language that I'm going to be very interested in see how it works out. So they're defining, one of the definitions for sensitive health information is diagnosis or condition. What does diagnosis mean? Are we including self-diagnosis? Because if we are not, a woman who goes, or a person who may be experiencing pregnancy goes and gets a pregnancy test, they have not yet been diagnosed. If a medical professional has not done the diagnosis, and that's how it's defined in that state regulation, they're chemically pregnant. But if we're defining this very narrowly as a doctor or a practitioner or a provider has to make that diagnosis, that means the time between when that person purchases that pregnancy test, whether it's on a record or goes to that location to purchase that thing to find out if they're pregnant, and the time where the diagnosis is made, any data collected during that time may be free for all. So it's worth thinking very carefully again about the language we're using when we write about these things. We mentioned miscarriage versus spontaneous abortion, but thinking very carefully about this time, space continuum and the language we are using to describe it.
Just one more thing about language. I love this so much, right? And I've had so many, I know, asked of you all. You probably think I'm bossy, but my family does too, so I don't care. It is spontaneous abortion or right-induced abortion. It is not elective abortion. Stop writing that. Elective is actually a term that we use when we're scheduling surgery in the operating room, right? And we're trying to triage the order of surgeries, right? If we're going to get bumped. It isn't elective, right? I promise you, for the person who needs the abortion, they are not electing to do this. I have never heard anyone who I provided abortion care for, who ever felt like they had a choice. The second language issue is around gender, being more expansive in the way that we're talking about it. I'm so deeply grateful for you throughout this talk for using more expansive language. And expansive, and I say expansive and not inclusive intentionally, right? We want to be expansive and generous in the way that we're talking about it. It does not hurt us to say people with the capacity for pregnant or pregnant people or individuals. So think about ways that you can be broader and braver in the way that you are talking about gendered language. That does not erase the reality that these restrictions are tied to gendered oppression. So we can talk about gender depression, we can talk about women, and also talk about pregnant people. We can hold these complicated thoughts. And then the last one is just an absolute on my knees begging to use first person language when you're talking about the people that I'm caring for, right? The stigma that is reinforced in so many of these articles is great. Low income people, right? As opposed to people living on low income. And so making sure that we're centering the person first before this identifier helps to reduce stigma, and it humanizes me as an abortion provider, right? A person who provides abortion care, and people who need abortion, not abortion patients, right? So understanding, it feels like a little tiny switch, but when I tell you, it makes a huge difference in the way that we talk about the work and think about the work. And I implore you to adapt some of these principles.
I want to thank all three of you for staying a little bit late and also for sharing your knowledge and perspectives with all of us. Thank you so much.